I am Jacqueline Smith, and I'm the Dean of the Faculty of Nursing here at UC. Thank you for being here so bright and early, as we like to do things in nursing, don't we? We've got some great food and even better conversation ahead, so please don't be shy about going back for seconds while the talk is going on. That's perfectly fine. I will just open us in a good way and recognize where we are. The University of Calgary is located in the heart of southern Alberta and both acknowledges and pays tribute to the traditional territories of the peoples of Treaty 7, which include the Black Confederacy, comprised of the SCHCS, the Piikani and the Kainai First Nations, the Tsuut'ina First Nation, and the Stoney Nakoda, including Chiniki, Bearspaw, and Good Stoney First Nations. The City of Calgary is also home to Métis Nation within Alberta, Nose Hill Métis District 5, and Elbow Métis District 6. It's my absolute pleasure to welcome Dr. Jacqueline Smith as our speaker this morning. Dr. Smith is an associate professor in the Faculty of Nursing at the University of Calgary and a wellness counselor in the Faculty of Nursing's Nurse Practitioner Mental Health and Wellness Clinic. She's also a trauma therapist, educator, graduate student supervisor, and published researcher whose work focuses on addiction and mental health. Dr. Smith and her multidisciplinary research team have been leading a 6-year Calgary Health Foundation study titled EMBER, Exploring Mental Health Barriers in Emergency Rooms. This research examines the mental health-related and substance abuse stigma experienced by both patients and staff in emergency departments, emphasizing how stigma continues to be one of the most pervasive and enduring barriers to accessing timely and compassionate mental health and substance abuse care. You may have seen her coverage of the study in the Calgary Herald last week or in You Today recently. In today's session, the EMBER research team will share key findings from the study, drawing attention to inequities within emergency department mental health care. The session will also explore how trauma and resiliency informed practices can support nurses and frontline staff in regulating emotional responses, fostering personal resilience, and cultivating self-compassion. These practices are essential, not only for enhancing the quality of care provided to patients and families, but also for safeguarding the well-being of those that provide that care. The EMBER findings reinforce a really important truth in frontline practice. We cannot give what we do not have. Finally, the team will discuss next steps for sustaining and scaling EMBER's evidence-informed practices with the aim of enhancing patient care experiences and promoting staff wellness across emergency and supportive healthcare environments. A bit of a trigger warning, this lecture will include discussion about mental health and addictions. Some content may be sensitive or triggering to certain individuals. Please take care of yourself throughout this. If you need to leave or step out or take a break, that's perfectly fine. Now, let's please welcome Dr. Jacqueline Smith.
Well, good morning, everyone. What a pleasure it is to be with all of you. We appreciate you taking the time early. Can you hear me? Should I bring this on? Yes, this was a 4:30 start for me this morning, so I'm sure for you as well, early start. So, is that better? So, really appreciated that introduction from Catherine, and I want to extend a thank you to the Faculty of Nursing and for all those involved in putting this together. Today, like Catherine shared, we're going to be sharing the findings, the evidence-based findings of our study into those patients and families who present in the emergency department, and what that experience is like for them, and also what the experience is like for the frontline workers who are working with them. We're taking a deep dive into our exploration. So I cannot continue, I think the word, without a sincere thank you to the Calgary Health Foundation for the support that they have provided, the financial support for this multi-year research project. Sorry, I'm just thrown off a little bit because I can't scroll. So it has been an incredible privilege to collaborate with a multidisciplinary research team. And what has happened over the 6 years is their collective knowledge, the expertise, and their genuine commitment to this work have significantly strengthened and enriched this project. So to begin with, I wanted to introduce our team. So Dr. Andrew Zito here today, he's a co-investigator and has been really involved specifically with the policy piece, and he'll be presenting on that. Dr. Eric Chan is a former psychiatric emerge doctor. He's now in Toronto, so we miss him today. Dr. Rachel Grimmick was also a former psychiatric doctor in Foothills Emergency. She's now in BC, but still a big part of the collaboration. Dr. Stephanie Mack, who's with us today, research consultant. She'll be sharing the quantitative data from our research today, so we're really grateful to have her. And a really unique feature, so proud of the fact that Emily Hilton has been with our project, with our research team from the beginning. So Emily comes to our team as a patient research partner. She is comes with experience, personal experience, family experience as well, and she's really the voice of the patients and families, and has been an incredible part of our research project. So we welcome her here today as well. Wafa Mustafa, I'm not sure if Wafa is here. Can everybody hear me? No?
Just a little closer.
Closer
to the microphone.
How's that? Okay.
Is that one?
This one? Okay. So Wafa, also a research associate. She's an advanced practice nursing nurse at the Peter Matthew Hospital. She's been very influential and a contributor to our research. Jen Smith, our project coordinator extraordinaire. She's just held us together, and a strong quantitative researcher as well. So she's been a big part of the team. And I can't miss out in also naming Sarah Owen, Emma Piglo, Hafsa, Jennifer Obiad, Sherry, Sarah Sass, Kiri Blackwell, and Christine Desjardins, boy, my eyes, who is a psychiatrist in Foothills Hospital as well. She's been, again, a big part of our team. So as you can see, we've had a very collaborative, multidisciplinary approach to this research. So, and I thought about this morning. 6 years ago, Andrew and I sat in my office knowing that we wanted to submit a proposal. We knew that the Calgary Health Foundation had sent out opportunities for us to do this. And when Andrew and I sat down, we realized that there was some research being done in stigma, but there wasn't that fulsome, holistic approach. And as Catherine mentioned, we knew that stigma remains one of the most pervasive and enduring barriers to accessing mental health care and substance use care as well. So we decided to take a deep dive and to really explore it holistically. We decided to look at 3 levels, so structural, which is the discriminatory and/or exclusionary policies, laws, practices, processes that happen within the system. The interpersonal level is the public stigma, the prejudices, the discrimination, and the languages that are often used to describe people with these struggles. And then the interpersonal, when individuals actually internalize this public stigma and the interpretation of what people with mental health and addiction are experiencing. So we chose the Foothills Hospital Emergency as our one site, and we wanted to really focus on one site to do it well with the potential for scaling and spreading. So we started with a needs assessment, which I'll talk about, but our participant group were, so we didn't want to presume what a stigma experiences was like for our participants, so we went to them in focus groups. We worked with patients and families, ED physicians and nurses, ED psychiatrists, psychiatric nurses, as well as protective services. this is really what we were looking for. We wanted to explore the factors that were driving this stigma experience, and we wanted to hear both from, again, the frontline staff and the patients and families. We wanted to then take all of that data and to implement some form of intervention that would really help to mitigate and really to support those struggling with this and hopefully to reduce the stigma. And we wanted to evaluate the outcomes from that intervention, and within that process as well, we wanted to really review, again, the structural piece, the policies and the procedures, really through a trauma-informed lens. And from there, we wanted to develop a plan to scale and spread, which we'll be getting to. We're very excited about that. So, began as a 5-year. We were given the green light to extend it to a 6-year. We're now right at the end. Data synthesis, recommendations, we've done a lot of publications, which we'll talk about, and we're really now doing knowledge translation, which is all about what we're doing today. So, this slide is so brief in comparison to the data. So just for a matter of time, I just wanted to share. These were the 4 main findings. We were at a workshop yesterday with the Mental Health Commission of Canada, and Stephanie just had the opportunity to really speak to it more broadly. But one thing we found is considerable stigma, especially structural stigma. Lack of inpatient beds, boarding. So for those of you who might not understand boarding, so when a patient comes into the emergency department and they decide that they need to be admitted, because there's usually no beds for them to be admitted to, they're put in the psychiatric area of the emergency department called PEDS, and it's there that they wait for that inpatient bed. Sometimes that wait can be days, sometimes it can go past a week. They're in rooms with no windows. Sometimes the door's locked, protective services standing out, 5 to 6 people sharing a bathroom, and maybe showers three times a week. So if they're not coming in with trauma and crisis experience, they're experiencing an emergency. Second, need for mental illness and substance use training. So many of the frontline staff said they did not receive the training that was needed to help support these people who were presenting. And the patients also picked up on the lack of knowledge of the frontline staff. They weren't being understood. Third, high levels of occupational stress amongst the ED staff. But what's really interesting, the 4th point, this occupational stress, everything that I've described to this point really falls under the umbrella of structural stigma. They're all interconnected. So the lack of inpatient beds, just everything, the lack of training, the distress. I had Stephanie and I and Emily did most of the interviews. I had visceral response to some of those interviews. One that stays in my mind is a nurse was working with a family. It was a young person who was going to be admitted, and they were past a week being boarded. They were crying every day, saying, please, please get me in. And so I did the interview with the nurse who told me she was resigning her position the next day because she said, I can't take the stress. So apologies being offered to patients and families, but yet, unfortunately, the change not possible. So after we received all of this data, we decided on an intervention that was already being implemented by the Fraser Health Authority. They were doing 8-hour training with some of their mental health and addiction staff in BC. So through collaboration, and we saw it such a fit, and Stephanie's going to be talking a little bit more about it, because she had been working with the Mental Health Commission of Canada with the Fraser Health Authority. And we knew that this was a fit. So I'm going to tell you a little bit. So I'm sure you've all heard about trauma-informed practice. So what we're going to introduce to you now is Trauma Resiliency Informed Practice. So I'm going to turn the time over to Stephanie to tell us a little bit about that.
Thank you. Thanks, Jacqueline. Hi, everyone. So as Jacqueline mentioned, that first phase of our research really directed us to the issues of lack of training, and the moral distress of staff. So we knew that this TRIP program, Trauma and Resiliency Informed Practice, we already had an evidence base established around it. We had already published in the literature about the effectiveness of this program as an intervention specifically for stigma reduction, as well as supporting staff wellness. So we knew it would be a good fit with a little bit of adaptation for an emergency department environment. But I still just want to talk a little bit about the evolution of the TRIP program in Fraser Health, because I think it offers some important lessons for any service setting that might be thinking about implementing trauma-informed care, trauma-informed training. And so basically the evolution is that Fraser Health Authority in BC first rolled it out as a traditional trauma-informed practice training. So teaching the principles of trauma-informed practice, very outward-facing. And what they noticed was kind of two things started to happen. One is that the participants who were taking the training, as they were learning about the effects of trauma and how trauma shows up, they realized that they had inadvertently re-traumatized patients in the course of interacting with them. And this created a huge amount of moral distress, right? They realized that they were harming patients without meaning to at all. And so what do you do with that now, right? What do you do with that, that kind of realization and that struggle? The second thing they noticed was as they were learning about trauma and how trauma shows up, they realized that they themselves were experiencing the effects of trauma, and that this was affecting how they were able to show up with their patients in the workplace, and it was affecting their interactions with their clients. So, Fraser Health kind of said, this is just not the right thing we want to be doing here, kind of an educator's worst nightmare in a way. So they pulled the bus over and said we need to figure out how to adapt the program so that we can attend to these issues. So they went to the literature and really basically fell upon the literature of mindful self-compassion, primarily Kristen Neff's work down in the States, and also literature around resiliency. They brought that literature and some of those resources into the training, reframed it, and so TIP became TRIP. So trauma-informed practice became trauma and resiliency-informed practice. And then also adding into kind of reframing the training as well as one that has a focus on compassion satisfaction. So really recognizing the kind of the moral distress, the compassion fatigue that healthcare workers talk about, and really trying to focus on that and cultivate that sense of compassion satisfaction and support compassion satisfaction in their work. So the central theory of change for the program essentially is you can't give what you don't have, right? So recognizing that compassion for others really begins first by needing to have compassion for self, right? So the program really focuses on first, let's focus on filling up our own cups, and then that will allow us to kind of give to others, and then that also cultivates compassion satisfaction. So that's kind of the core thesis that we really wanted to maintain when we did our adaptation. And then I'll give it back to Jacqueline for a minute here to talk about our specific adaptation.
Thank you. Yeah. So now we had a model that we were very excited about, and it already had been tested within the Fraser Health Authority. So this is how we decided that we wanted to deliver it. First, we wanted to really educate. So again, all of our participants were invited to this. So frontline staff, this is not patients and families. We wanted to impact the care of patients and families through giving that resilience-informed practice to our frontline staff. So first we talked to them about the neurobiology of trauma. How are they actually experiencing the vicarious trauma that they were being exposed to in the emergency department? And then we just really wanted to increase their own awareness of what was happening to them in relation to the work that they were doing with these people who were presenting with mental illness and addiction and trauma responses. And what was happening is that we found that once we started teaching them about how they were personally experiencing it through the lens of self-compassion, then they had this level of compassion for others. So can't give what we don't have. First, they were understanding that they were being impacted. And then we were teaching them emotional regulation tools throughout the training as well to help regulate. Even when we were talking about these emotionally triggering topics that Catherine was alluded to at the beginning. And at the end of the day, we really wanted to strengthen the resilience and self-compassion practices, and we wanted them to learn strategies as well to help them with the reduction of stigma toward, again, mental illness and self-issues. And that fostering of compassion satisfaction, that was a new term for me. And what I came to understand is being able to, I'm a former ER nurse, but being able to feel that when you left your shift at the end of the day, feel like you made a difference, even in a small way. So we really wanted to shift that hopelessness that so many of the frontline staff were experiencing to a sense of hope, that they could contribute the best that they could after becoming resilient themselves. So we launched it. Now remember, this is an emergency department. They're taxed, and it was, we knew that 8 hours wasn't going to work. So this 4-hour training was pretty significant in being able to adapt it to the frontline staff. So we did virtual sessions. So as you can see, we had protective services involved. We had psychiatric residents, and I'll tell you a little bit about that. So one did the full 4-hour. We did psychiatric nurses were involved, ED physicians, ED residents, nurses, educators, and we had some allied staff as well. What was really neat is that amidst all of this, Dr. Rory Selmer was, and he's the head of psychiatric residency at Foothills. He became aware of this training, and he said, I really want this for our psychiatric residents. So because they were already amidst training and did a lot of the neurobiology components up front, we were able to deliver another adapted version, 2 hours, that was delivered by Dr. Eric Chan, who is already a part of the training for the psychiatric residents, as well as Christine Dr. Christine Desjardins. So pretty incredible that we were able to train frontline psychiatric residents as well. So now we're going to tell you a little bit about the outcomes of the delivery of that intervention. So back over to Stephanie.
Thank you. Okay. So our findings. So basically the evaluation protocol that we used was very similar to the previous evaluation that was done in Fraser Health, right? We used similar metrics because we wanted to kind of, check around fidelity, like were we going to be able to see consistent or similar results, even though we were adapting the program to a much shorter version. So we actually captured 2 stigma measures, mental illness related stigma and substance use related stigma. To capture mental illness related stigma, we used the validated Opening Minds scale for healthcare providers. And for substance use stigma, we used the Opening Minds provider attitudes towards opioid use scale adapted for substance use more generally. And what you can see here, so in this scale, lower scores mean less stigma. And we measured pre-training, post-training, and at 6 months follow-up. And what you can see here is we saw statistically significant improvements in stigma for both mental illness-related stigma and substance use-related stigma that held at 6 months, which we're really thrilled with, because a lot of interventions you see initial gains and then kind of creep back up to baseline after. So we are very excited about these findings. These were large effect sizes between the pre and post, which is very consistent actually with the Fraser Health findings. So we're feeling really encouraged by that. For the 2-hour version of the workshop, which was delivered to the psychiatric residents, they had much lower scores, less stigma to start off. Didn't actually see a lot of change. We don't really know why that's the case, but that's what happened. For substance use stigma, we did see a statistically significant improvement. Also, they're also starting at a lower baseline, so less stigma to begin with, and we did see it improve, but unfortunately bounced back up to baseline at 6 months follow-up. For our wellness outcomes, we used 2 different scales, a resiliency scale, which is actually an ad hoc scale, but it's been used in several other evaluations, including the Fraser Health evaluation, and I just need to tip my hat to Andrew Zito because he actually developed the scale. It's also used for the evaluation of the Working Mind program, which many of you might be familiar with, and Dr. Keith Dawson also collaborated on that scale. So we consider it ad hoc, but it basically might as well be validated because it's been used so much. And then also the short version of Krista Neff's self-compassion scale. So those were kind of our key outcomes is, did it improve resiliency and did it improve self-compassion? So again, for the 4-hour workshop, the main workshop, we again saw statistically significant improvements. These scales, higher scores mean improvements. Statistically significant improvements that held again at 6 months follow-up, so really encouraged by that. For the self-compassion scale, we saw an improvement from pre to post program. It was not statistically significant immediately after, but by 6 months follow-up, it was. So we saw increasing gains. We think what happened here is that self-compassion was kind of a new concept for a lot of the participants. So, and it's something that you have to learn how to practice, right? So we think that basically they went away and actually started practicing what they learned in the workshop, and as they started to practice, it actually did develop their self-compassion skills and their self-compassion practice. So feeling really encouraged about this, as it tells us that the program was valuable to them and they actually used it, right? And it was meaningful to them. For the 2-hour workshop, we did see improvement in resiliency skills that did hold at 6 months. The continued improvement wasn't statistically significant, but it was also a smaller group. So we may have been underpowered. But anyway, nice to see it hold. For self-compassion, we did see an improvement from pre to post. It was not statistically significant, but I think that was a power issue, although we don't know for sure. But unfortunately, it did not hold at 6 months. So we saw reductions back to baseline. Okay, so those are our quantitative measures. Any questions about that before I move on to our qualitative findings? Oh, okay, straightforward. Okay, so we also, in our evaluation, we also asked participants to describe the value of the program to them. What did they get out of it? What were the strengths? What were the skills and learnings they wanted to take with them? And basically the themes were they planned to apply the TRIP principles, which is amazing. And then they articulated that in a little bit more detail in many ways. So some of the ways that they will plan to apply the TRIP principles was through language changes, right, through reframing and changing the way that they communicated, through more empathy and listening in their interactions with clients, by encouraging patient choice and involvement in their care, which is directly one of the principles of trauma-informed care. Their intention to engage in self-compassion practices, and to utilize the emotional regulation and grounding techniques that they use in the program. And we asked them these questions both at post and at follow-up, and at follow-up they did mention that they were in fact using these skills and techniques in their practices. And they talked about using this stuff both in their personal life and in their professional life. So I just want to highlight a few comments to kind of, bring it to life a little bit. So one participant nurse here said, words, perceptions matter, and self-care. I'm going to be focusing on the what happened to you versus the what's wrong with you. Finally, asking the individual what they want me to know and or understand to support their care. So really kind of bringing alive some of the principles of trauma-informed practice. Another, this is from the psychiatric resident. And this person said, I want to try to find a moment of compassion and love for each patient and to suspend judgment. Finding space to be more reflective, less colonial responsive, seeking answers, more listening for answers. Another ED nurse, so this is from the 4-hour workshop. More people getting the training would help TRIP become the norm in the workplace. The overall organization listening to and acting on suggestions from what frontline staff feels would help patients and themselves feel safer. So one of the other themes was, what improvements would you like to see? And most participants just said, we'd just like to see it rolled out more, right? We'd like to see booster sessions, refresher sessions. We'd like to see it integrated. We'd like to see it offered to more staff. So that is a theme that supports that. And then a last quote here. this nurse said self-compassion, breath work, listen to your inner critic, and replace with the inner ally, were things that they were going to be practicing. And I do want to highlight too that even though the 2-hour workshop, the quantitative findings were less robust overall, the qualitative comments were very similar, right? Like we really didn't see a difference, so they still really valued the program. And the training, we're just not quite sure why we didn't see, you know, why we didn't see kind of the results holding. We don't know if it was, we don't know if it was something about the participant group. We don't know if it was something about a dose effect, right? Maybe we cut it a little too short. We need a bit more research. But the 4-hour adapted version, it really did hold up, and it showed effectiveness in stigma reduction and increased self-compassion and resilience skills with those gains sustained, which is really wonderful. We learned that the participants highly valued the training, and they are indicating that they are using the skills taught, both the trauma-informed skills as well as the resiliency and self-compassion skills. So less robust outcomes in the 2-hour, so we basically need more research to figure out why. And really, a lesson learned is, healthcare leaders are encouraged to explore how TRIP may be implementable in their organizations. I think it is really, the demand is high. I think the value is high. So, kind of any little window or opening to be able to offer this in other environments would really be amazing. And then ideally, this was the feedback we got too, that TRIP ought to be implemented with booster sessions or refresher sessions or some kind of community of practice. Participants really did want some way to kind of keep it alive and keep it moving forward, which we weren't able to offer as a part of this project, but hopefully in future implementations we will. Okay, so that was our TRIP intervention. Now I'm going to hand it over to Dr. Zito to talk about the policy component of our project.
So, good morning everyone. It's good to see so many people out and attending breakfast. I know it is a little bit early for me, but that's okay. So, and thanks for Jacqueline for harkening back, many years ago in our conversations. In thinking about stigma, so I'm a stigma researcher myself, and I've been doing this for quite a long time now. We do address stigma at the interpersonal level. We do address stigma at the intrapersonal level, so public stigma, self-stigma, but very little do we address broader structural stigma. And we wanted this project to be holistic in the sense that it addressed all those pieces, right? And thinking about this, we think addressing policy should be a priority for this project. So when we started off, we looked into the literature, we did consultations with various groups, AHS, for example, and even in phase 1, all those things pointed out to, yes, you need to address the structural piece, we need to address policy, right? So policy is a very important piece in all this, and as we really went through the literature, went through the consultation data, and really, again, looked through all the things that existed out there, everything was pointing, yes, stigma and policy, particularly at addressing structural pieces, is important. Yes, please address that. But that's about it, right? We set out to think about, policies. Yes, let's think about policy. How do we think about these policies through an anti-stigma lens? Let's look for the tools and things that help us do that. Well, again, the literature said, yes, policy is important, let's address this, but again, nothing was there, right? So really, really important piece. So we found out very quickly we wanted to review tools that address stigma. But again, none of those things existed, so we kind of switched gears, and how we wanted to do that was to really think about all the themes that came up through the literature and what it said. So what it said was that, and again, I do have to thank our team of researchers. Emma is here, I see her, I was looking for her, so Emma, right there, raise your hand. She's one of our researchers that have been, research assistants that have been working on this project for a long time now. But what we did was we looked through the literature, what we found and compiled and looked at the themes, right? We found that specific recommendations on how to reduce stigma at the policy level, kind of three buckets, right? There's policy development, so that's one important phase of the policy development cycle, or sorry, the policy cycle, policy implementation, as well as policy evaluation. So those are the three important phases. There's separate components that fit into each of the phases. So in policy development, what we found was that engaging in meaningful co-creation, so including all those people that are important, so it's particularly people with lived experience, right? Those with who are coming to the accessing care, those with mental illnesses, those who are experiencing substance use issues. We need to include those, as well as the policymakers, as well as psychiatrists, as well as nurses, right? All those people are important, and not just being token pieces, people as part of whatever it is, but really integrating it and having their being part of the process, using non-stigmatizing language throughout the policy, and really considering quality of care principles as impact pieces through for the policy. So that's the policy development phase. And policy implementation is really about awareness and having other pieces that address stigma in addition to the policy. Clear communications, things like that are really, really important. And evaluation is important. So we talked a little bit about evaluation and why, really showing the outcomes and impact as well. So we did that review. We're almost, I don't know what it says there, but we're almost ready. We finished, it's ready. We're just looking for a place to publish or try to submit. So with, what I said at the beginning, we set out to, wanting to at least review tools to review policies through an anti-stigma lens. We couldn't find any, so we came up with these recommendations. So we thought, well, with this paper, let's develop the tool. So we're in the process now of developing this tool that will review policies within the healthcare setting to reduce, through an anti-stigma lens, right? So really reducing that stigma piece. Emma is working on that piece right now, and what we're doing is really taking those three phases and those components within each phase and really working at, so for example, we have a section on stigmatizing language, right? So what are the things that we should consider when we're developing this policy? What language should we be using? How should we talk about all these things within the policy? As well, there will be checklists on, are you addressing the necessary thing, as well as additional resources to think about this component. So we're going to build up this full resource, look for that as we move forward in the future. So essentially we're at this phase where we're building this tool. Hopefully this tool will be useful for not just policymakers, but those in the settings, in the clinical settings, those who are administrators within the healthcare setting and the ER are able to use this to really think about the policies that they have, how they're implemented, and to think about the evaluation piece as well. But I do, again, want to acknowledge the people who have worked on this aspect of the project. So Emma is one of the people who, as well as Laura Henderson, Spencer Chen, and then also Dr. Grimmick, who has worked on is leading teams right now for the broader EMBER project. So thank you all for coming back to the
Thank you so much, Andrew. So I hope you're starting to get a feel of the multi-layers of the project from the beginning. Now I want to introduce another one. I love the language of serendipity. So as we were implementing the intervention and really noticing that the overarching problem was structural stigma, Dr. Stephanie Mack let us know that the Mental Health Commission of Canada had actually just completed some psychometric testing for a Stigma Cultures in Healthcare scale, and they were looking for a site. Well, we were in there. We were so excited. We signed up. So amidst the work that we were already doing with the Trauma Resiliency Informed Practice, we partnered with the Mental Health Commission of Canada, and we did it at Foothills Hospital site. We already had that agreement with them, and again, using the scale. And we wanted to really look at the impact of structural stigma at Foothills Hospital over time. Now, it was interesting because some things were starting to change at Foothills Hospital, and we had we had a little bit of a pre-assessment as well too. So we knew that there was a change in the psychiatric model, so the nurses were now in PES were working 24 hours. Before it was the emergency nurses who were taking care of the psychiatric patients and those with substance use disorders. We wanted to evaluate the effectiveness of the pre-post trip evaluation and the physical changes in the ED department. So I'll just briefly tell you that when we started our project, we knew that there was funding for renovations in ER. 6 years later, the changes hadn't occurred. So we weren't able to do that pre-post. But I have been reassured that that funding is still there and that fire has been reignited. So we're getting brief in our time. So I'm going to let Dr. Nat come in now and talk a little bit very briefly about that scale and how it was rolled out.
Thank you. Okay. To speed things up, that's your hint. Speed it up. Okay. Yeah, as Jacqueline mentioned, we were so thrilled to be able to collaborate with the Mental Health Commission and be a pilot site to test out these scales. So these scales, and just a nod to our commission colleagues in the room here, Kamlesh and Hannah, and Anita was also here earlier but had to head home. We were actually doing structural stigma workshop yesterday on campus. So yeah, so lots of stigma work these days. So this scale is actually meant to capture the downstream effects of structural stigma from the perspective of patients themselves. So it was a really exciting opportunity for us because it was a way that we can maybe hopefully indirectly measure the impact of the TRIP rollout. And then as Jacqueline mentioned, it also allowed us to capture a very significant structural stigma change in the ED. Like one of the main themes from our qualitative research was this issue that ED nurses were responsible for the bedside care of mental health patients, but they didn't get any training in it. So this was a real complication. So to find out that the structural change was coming in, and psychiatric nurses were going to look after the bedside care, it allowed us to actually track the impact of structural change. And so these are the items that were used in the scale. So it's basically kind of a hybrid of two scales. The first 23 items are kind of questions that are meant for kind of any general kind of healthcare setting. The additional 7 items there, or I guess 8, are there's 7 items that kind of comprise a coercive care component of a mental health specific scale. And then the final item we analyzed separately. It was an item from the mental health care scale. And the item is the space was comforting. And we pulled that in the hopes that these ED renovations would get done and we'd be able to measure the impact. So just briefly, in terms of our recruitment, we recruited using posters in hospitals and volunteers, handing out postcards in the waiting room. We had research assistants on site at the bedside asking folks. And so we allowed anybody to complete the survey if they had visited the ED within the last year. And basically to date, we're still collecting data. We're still kind of ongoing. We've got 558 surveys completed. And our sample is basically 39% have visited the ED for physical health reasons only, 41% for mental health reasons only, and 20% for both. They came in with multiple complaints, both physical and mental health related. And what were our baseline findings? So basically we measured, the Stigma Cultures and Healthcare scale, kind of the general scale, the coercive care factor, and then the space is comforting. And what we found is basically folks who visited the ED for both mental health and physical health problems together had the most negative experiences. They had the worst experiences for these 2 items. And these were all statistically significant, kind of in between, right? And so it validates our initial qualitative findings that definitely mental health patients with mental health problems are experiencing more stigma in the ED. For the last item, the space is comforting. I think that also validates the issue that came out of our qualitative research that these psychiatric beds feel like jail cells. It is the folks probably who are just coming in specifically for mental health complaints who are most likely to find themselves in those beds. So very much kind of validated our initial findings. And just some qualitative results here too. I won't go through them in detail because we are short on time. But again, it really just speaks to, it really kind of validated what we found in our earlier research. Lack of respect, disconnect between mental health care, physical health care, a distressing physical environment, excessive wait times. I don't think any of this comes as a surprise, right, to see it. Okay, now the really exciting stuff, the pre-post. So as Jacqueline mentioned, we measured kind of before the changes in the nursing model and the rollout of TRIP, which serendipitously happened around the same time, and then measured again after that change happened. And what we see here is our two scales. And we measured the experiences of just mental health patients, right? So this is just the mental health patients within our sample. And we see that experiences improved pre to post these two changes. So we don't know how much it was TRIP and how much it was the nursing model, but very encouraged to see that it actually did make a positive difference. So yeah, and we're continuing to collect data on this, and we'll see what happens down the road. Now I'm going to hand it back to Jacqueline to wrap up.
And I promise we will wrap up, but I kind of wanted to save almost the best to the last. So we have been doing lots of knowledge translation. We've published with the International Journal of Mental Health and Addiction, a couple publications. We have a third out. We've got, I think, 3 in the works now. Lots going on. But let me tell you about serendipity again. So here we have our statistical significant results, and we're meeting with our stakeholders, which we do quarterly. And Jessica from the Viewpoint Foundation is, where are you, Jessica? She's, oh yeah, there you are. She's at our session, and within 15 minutes, once we complete, she sends me an email and she says, I am working with the Calgary Drop-In Center, and this is exactly what they need. Would you go and present? So I never forget Ben's words, so Calgary Drop-In Center back. So we went, KT, and he said he was vibrating after. And he said, this is exactly what we need. Would you come in and help us? So it was like, okay, we're doing, this is KT, but now you're asking us to do another project. So long story short, we really work with them, and the more they became familiar with Trauma Resiliency Informed Practice and how it's really supporting the frontline staff, they actually came to us subsequently and said, we want you to train all of our staff. We're talking like over like 550 staff. So we thought, okay, this is another project. But this is exciting. This is every researcher's dream, to be able to take a research project and to translate it into a sustainability way. So amidst all of that, we're in the process of becoming accredited with TRIP as well. We needed a project attached to that, so that was happening. But the other big piece was, this is another project that needed funding. So what did we do? We went back to Jessica. We said, Jessica, we want to do this, but we need some money. So we put together a proposal, and of course, who came to the place? Calgary Health Foundation, with this perpetual sustaining funding. They match funding. Calgary Drop-In Center is coming in for that funding proposal, and we are meeting all together for the first time after this breakfast today. So I am so excited for this opportunity to translate now this evidence-based intervention into a sustainability plan. And in addition to that, our team is working the translating research to action with the team here at the University of Calgary. We're part of a cohort, and they're working with our team now to help us to build the sustainability plan. We delivered it to Foothills Hospital Emergency, to a fairly, not a large cohort, and now we're talking 550. So we're needing lots and lots of training. We're already looking at facilitator training as well too, but really excited about this. So I just want to end with a huge thank you to all those who have supported this project. And at the end of the day, yes, we can't give what we don't have, but all of this is about impacting the outcomes of the patients and families who are presenting in the emergency department. And it's our hope that this sustainability, this knowledge translation is going to get to the structures, to the organization that is bumping up against really the work that we're doing. We're supporting, but we want to get past the staff having to apologize for the system. And we hope eventually that this is going to translate into a change in the structure as well. So again, thank you all for being here. A huge thank you to my incredible team. I hope you had a feel for the expertise that has been a part of this project. So enjoy the rest of your day, and please reach out if anybody wants to know a little bit more about the project. So thank you very much.